Bismillahirrahmanirrahim. In this video, we'll discuss the antibiotics that inhibit bacterial cell membrane. And again, we have this scheme of the antibiotic classification. The bacteria that inhibit cell membrane, we have a polymyxin and lipopeptide. The polymyxin, the colistin, is the one of the group of the polymyxin is polymyxin E, and the lipopeptide, the daptomycin, is the one of the lipopeptide antibiotics. We start by the polymyxin. The polymyxin coverage, it's mainly covering the gram-negative bacteria and Pseudomonas. But keep in mind that there is some bacteria that intrinsically, of the gram-negative bacteria that are intrinsically resistant to the colistin. And these types like Serratia, Proteus, Providentia, and Morganella. So if you have a bacterial identification without culture, and these types of bacteria appear in the lab, we have this means that you cannot give colistin to these types of bacteria because it's intrinsically resistant to colistin. The colistin is concentration dependent, which means that we need to do a loading dose followed by intermittent bolus. But how we can do that? The colistin first is available in the market at what's called colistin what's called CMS. And this is either in the international unit or milligram per drug. But we need to calculate first the dose in the colistin in the colistin-based activity, which is called CPA of the active drugs. Then we will convert the colistin-based activity to the formula available in the market. Every 1 milligram of the colistin-based activity equals 30,000 international unit of CMS or 2.4 milligram of the CMS. Then we calculate the loading dose, which equal 4 multiplied by the actual body weight. There is no renal dose adjustment. Then we start maintenance dose after 12 hours from the loading dose and divided this in 2 to 3 doses. Then the maintenance dose is adjusted based on the kidney function. Let us see some working example to know how can we do that in a real patient. We have this patient 80 kilogram creatinine clearance is 80 milli per minute. And this is part in the adjustment based on the creatinine clearance. First, we calculate the loading dose in CPA activity. 4 multiplied by 80 to this patient need 320 milligram of the colistin-based activity. Then we will convert CPA to CMS. So if we have the drugs in the market in the international unit, we will multiply 320 by 30,000, so we need 9.6 million international units. Or if we have the drug in milligram, we'll multiply this amount by 2.4, so we need loading dose 768 milligram. Then we start maintenance dose. The maintenance dose based on the creatinine clearance. So if we have patient with creatinine clearance between 50 and 90, so we need 30 milligram per day of CPA. So we multiply 30 milligram per CPA. This patient have a creatinine clearance is 80 milli per minute. So we need 300 milligram per day. So 300 multiplied by 30,000, we need 90 million international unit maintenance dose or 720 milligram. Then we'll start maintenance dose after 12 hours in 2 to 3 doses. So we'll divide these doses in 2 to 3 doses, either 4.5 million international unit every 12 hours, or 3 millions every 8 hours. Or if we have the dose in milligram, we have 360 milligram every 12 hours. The colistin also can be given as an inhalational or intrathecal. For inhalational colistin, ideally, the dose will be 50 to 75 milligram colistin-based activity in 3-4 milliliter saline. Ideally, we need to use mesh nebulizer. We need to avoid the usual nebulizer, the jet nebulizer, because the mesh nebulizer provide about 50 to 60 amount of the drug to the lung, while the jet nebulizer provide only 10% of the amount of the drug to the lung. And typically, we need to combine the inhalational therapy with the IV therapy. For intrathecal, we give 10 milligram CPA per day, and Again, we will use this with intravenous therapy. Colistin side effect, the main side effect is neurotoxicity, vertigo, confusion, ataxia. Neuromuscular blockade may induce respiratory failure and may exacerbate myasthenia gravis. It also may induce nephrotoxicity, but in the form of reversible acute tubular necrosis. For the lipopeptide or daptomycin, it's mainly anti-gram-positive bacteria. It covers all types of the gram-positive, including strep, staph, MRSA, and enterococcus, but no activity against the gram-negative. The daptomycin used mainly for skin and soft tissue infection, for bloodstream infection, but we don't use daptomycin for pneumonia because this drug will be inactivated by pulmonary surfactant. The side effect, the main side effect is myopathy. So you need, if you administer this drug, we need to have a CPK weekly and stop the drug if the CPK more than 5 times the normal with symptom or more than 10 times the normal value without symptoms. And also one of the side effect is what's called eosinophilic pneumonia, especially with long-term exposures. Diagnosed by new infiltrates in the lung radiologically, new worsening of the hypoxemia, and we have a sign of the high eosinophil either in the bronchoalveolar lavage or in the total leukocytic count. By this slide, we end the first classification of the second classification of the antibacterial that act on the cell membrane. Thank you.